Well, hello, friends, and we're excited today about another installment of Kidney Talks with the George Washington University Ron and Joy Paul Kidney Center. Today, you're in for a special treat, and we'll be talking about the state of emergency, Black women and their gynecological health. And we're just excited today to have Dr. Clive Callender, Dr. Joseph Keith Melanson, and a special guest that I'll let Dr. Callender introduce um, here shortly. The It's just a wonderful time, and we're going to have not only the Ron and Joy Paul Kidney Center, we also have a unique sponsor in MOTEP, which is a Minority Organ Tissue Transplant Education Program, and also the Pennsylvania Avenue Baptist Church. And I'm your host, Reverend Kendrick Curry, and we have Dr. Clive Callender and Dr. Joseph Keith Melanson, who are esteemed transplant surgeons and leaders in their respective fields, and they're here to give us some insight. But Dr. Callender, I would turn it over to you to let you just say a couple of sentences about the exciting guest that we have with us today.
Yeah, we're excited to have Dr. Elena Callender, who's an obstetrician and gynecologist who has a special expertise in public health, in addition, who has a background also as a journalist, who's going to tell us about this state of emergency as it relates to women's health.
Amen.
Dr. Callender.
Welcome.
Hello, everyone. As the senior Dr. Callender mentioned, I'm an OBGYN with a degree in public health, and I'm a generalist OBGYN. We're going to talk today about what we're calling of emergency, Black women and gynecologic health, because of some things that have been happening lately that have put a spotlight on the importance of Black women understanding their gynecological health. So we'll go ahead and start the presentation. And this slide is about Miss Jessica Petway. She's someone that has been in the news lately because of an ordeal that she went through with misdiagnosis of a GYN cancer that ultimately led to her death at 36 years old. She initially started this journey in June of 2022, at which time she had several episodes of heavy bleeding, to the point where she had to be hospitalized. She had blood transfusions, and one time she actually passed out at home. Every time she went to seek care, she was told that her bleeding was because of the fibroids that she had. The fibroids are a benign mass that can occur in the uterus, and they occur in very often in women. Some know they have them, some women don't. But she suddenly had this bleeding and was told that she had fibroids, which is a benign condition. The next year in February, was when she was finally diagnosed with advanced cervical cancer. And she had diagnosed after she did a biopsy with an oncologist. By March of this year, she was dead, and she had died from cervical cancer. Another story I have to tell you on the next slide is about Adrienne Moore. This was a 45-year-old respiratory nurse in Atlanta. In 2012, she started to have pain and bleeding with intercourse and irregular periods. She was told she was perimenopausal, or that she had ovarian cysts or fibroids, all of these things being normal or benign conditions. Over the next 3 years, she didn't have any improvement. And every time she went to the doctor, she never got a final diagnosis. She ended up having to miss work often due to worsening pain and bleeding, and she ultimately lost her job and her health insurance. After a year, she got another job and new health insurance and began seeing her again. So 4 years after her symptoms began, she finally was diagnosed with advanced endometrial cancer. She is still alive. She has undergone treatment and is now in remission, but it took her over 4 years to even get a diagnosis. So I'm going to point out some of the racial disparities that we see in gynecological cancers on the slide. Some of these disparities include misdiagnosis or delayed diagnosis. We know that Black women experience higher rates of death from many GYN cancers, and women and racial and ethnic minorities are 20 to 30% more likely than white men to experience a misdiagnosis. Move to the next slide. And then the next one. So today I'm going to talk about some common GYN cancers. In this picture, we just I just have pointed out some of the main areas. There's cervical cancer, ovarian cancer, endometrial cancer, vulvar, and vaginal cancer that can occur in women. Next slide. We'll start by talking about cervical cancer. It is unique. It is one of the most preventable and treatable types of cancer. For gynecologists, this is sort of an area that we are very proud of because we know a lot about cervical cancer. We know what causes the great majority of it, and we know how to prevent it. So through vaccination and screening, we can essentially eliminate cervical cancer. So it's very unfortunate, and it just really shouldn't have been that women should be dying today of cervical cancer. Next slide. HPV is a virus, a sexually transmitted virus that causes the majority of cervical cancers. Unfortunately, more than 4,000 US women die from cervical cancer a year. It's most often diagnosed between the ages of 35 and 44, and it ends up being the fourth most common cancer in women worldwide and the fourth highest in cancer-related deaths. Next slide. Black women are 8% more likely to die from cervical cancer than white women. For white women, the 5-year relative survival rate is 67%. For Black women, that rate is 56%. Non-Hispanic Black women make up a disproportionate number of new cervical cancer cases and are more likely to be diagnosed at later stages, where treatment is more difficult and women are more likely to have complications and more likely to die. Next slide. A study done by the Southern Rural Black Initiative for Economic and Social Justice and the Human Rights Watch, this looked at factors contributing to disproportionate cervical cancer death rates for Black women in Georgia. Next. And they found that in Georgia, Black women are almost 1.5 times more likely to die of cervical cancer than white women. And these disparities just worsen as these women age. Black women are more likely to have never been screened at all for cervical cancer. They're more likely to be diagnosed at a later stage, and they have lower 5-year survival rates. Next. Black women in the study described callous treatment in the healthcare system, an inadequate level of care, and concerns about confidentiality. And these issues, they said, undermine their trust in doctors and the healthcare system, alienated them from getting gynecological care, and contributed to poor reproductive health outcomes. Next. Early versus late stage diagnosis in cervical cancer is very important. When it is diagnosed at an early stage, 5-year survival rate is over 90% for white women and 85% for Black women. When it's diagnosed after it has spread beyond its cervix to other organs, the survival rate drops to 17.2% for white women and 15% for Black women. So we can prevent this cancer, but if we don't until it's late, then the death rate is very high. Here are some symptoms that women can look out for. Any unusual vaginal bleeding, a change in your vaginal discharge, an increased amount of discharge, a change in the thickness, pain or bleeding during sex, persistent UTIs, difficulty having a bowel movement, swelling in the legs, or bone pain. And these are symptoms that would be considered advanced, or that would be more likely to be seen in advanced cervical cancer. Next slide. The most important thing about cervical cancer is prevention. And we have a vaccine, it's called Gardasil, that is offered to girls starting at the age of 9, and it can be given up to the age of 45. Starting at age 21, women should get a pap smear at least every 3 years. From the age of 30 to 65, prevention can involve pap smear alone, HPV test alone, or having both tests together. And the pap smear is a test that actually looks at the cells on the cervix. The HPV test just determines whether whether there is the presence of that virus that is likely to cause cancer. And when we do these tests, it's at a point that we can see cell changes very early, so that if we take care of the issue when it's very early, a woman will never ever be diagnosed with cervical cancer because we have found it at such an early stage. Over 65, women may not need any further cervical cancer screening if they've always had negative tests, and if they've had 3 normal pap smears or 2 normal HPV tests in the preceding 10 years. Next. So we can talk about ovarian cancer now. This is the #1 cause of death for gynecological cancer in the United States. About 20,000 women are diagnosed each year, and about 13,000 women die from ovarian cancer each year. Next. There are several risk factors for ovarian cancer. It occurs more likely in women over age 55. Any woman with a family history of breast cancer, ovarian or colon cancer, or endometrial cancer is at risk. Any woman with a personal history of breast cancer, and certain genetic mutations and syndromes increase the risk of ovarian cancer. Never having had children, a history of infertility, and endometriosis can also increase the risk. Next. Most often, ovarian cancer doesn't have any symptoms. And while there may be symptoms that present, they are very vague. So it's important that if you feel like something's not right, that you see your doctor. And if you see your OB/GYN, it's important to get a pelvic exam. Some of the symptoms can include bloating, pelvic or abdominal pain, urinary frequency, upset stomach or heartburn, fatigue. So as you see, these symptoms can be associated with other disorders. So it's very hard to pinpoint the fact that they might be pointing you towards ovarian cancer. But if you have any of these things, it's important to seek medical care. Next slide. We'll also talk about endometrial cancer. And the endometrium is the lining inside the uterus. This is where women, when we bleed during periods, is where that's coming from. So on the next slide, this type of cancer is also referred to as uterine cancer. It is the most common type of reproductive cancer and the second deadliest gynecological cancer in the US. Most cases are diagnosed in women who are postmenopausal and are in their mid-60s. The age-adjusted mortality for Black women is 84% higher than among other women. Risk factors. Risk increase with age. Obesity, diabetes, and genetic cancer syndromes increase the risk. A history of polycystic ovarian syndrome. A history of breast cancer that's been treated with tamoxifen. A woman who starts her period at a young age or goes through menopause at a later age is at increased risk, and women who've never been pregnant are at increased risk. The most common symptom is vaginal bleeding after menopause. This is important to note, and that means any amount of bleeding that happens after a woman has gone through menopause is abnormal. It doesn't have to be heavy. It can be a spot or two, but any bleeding after menopause is abnormal, and women should seek care for that. During a woman's menstrual years, any change in her bleeding, whether heavier, lighter, or bleeding in between periods, should push the woman to seek care. Symptoms that are consistent with more advanced endometrial cancer include abdominal or pelvic pain, pain with intercourse, bloating, feeling full quickly after eating, changes in your bowel or bladder habits, and unexplained loss. Some of the racial disparities that exist with endometrial cancer include that Black women are nearly twice as likely to die from endometrial cancer as white women, even though the disease is slightly more common among white women. Aggressive forms of endometrial cancer appear to be more common in Black women. Black women who have a history of uterine fibroids have a 40% higher risk of endometrial cancer. And compared with white women, Black women have 2 to 3 times the incidence of uterine fibroids. They have an earlier age at first diagnosis and greater disease severity. Black men are also less likely to be evaluated based on established guidelines. So the next slide. Black and Hispanic women are less likely to receive surgery, hysterectomy, or definitive surgical treatment. Minimally invasive surgery is performed less frequently in Black and Hispanic women. Black and Hispanic women are less likely to have lymph node sampling or dissection, and Black women are less likely to receive chemotherapy. So the endometrial cancer workup should include these following things. Most important of these things, I believe, is a history and physical exam. The doctor should go over the woman's history, including her current symptoms, as well as other medical problems, and to do a thorough physical exam. One of the first tests that is recommended is a transvaginal ultrasound, and this will allow the physician to see abnormalities in the uterine lining. This may be an initial test, but it is not a diagnostic test for endometrial cancer. Unfortunately, due to the high incidence of uterine fibroids in Black women, this test is more likely to miss cases of endometrial cancer in Black women. The ultrasound scans that measure the thickness of the uterine wall are less accurate when patients have the more lethal non-endometrioid type of cancer, which is more common among Black women. So this may not be an appropriate test for the initial evaluation in Black women. The next step would be an endometrial biopsy, hysteroscopy, and or DNC. These are tests that would allow for the diagnosis of cancer. A biopsy can be done in the office, and it involves using a small device to remove a sample of tissue from inside the lining of the uterus. In the laboratory, they can look at the cells in the tissue and determine if there are any abnormalities there. Hysteroscopy means we take a small camera and actually look inside the uterus and see any abnormalities or masses that can be causing irregular bleeding or whatever symptoms are apparent. And the DNC means actually removing some tissue from inside the uterine lining. And all of these would be diagnostic. So we've talked about some of the disparities and some of the problems with misdiagnosis or delayed diagnosis. So I want to talk now about how to be your own advocate in your healthcare. One thing that I think is very important is that you know your family history. Ask your family members about their history of GYN disorders and other medical problems. This information can be very helpful when you and your doctor are discussing what might be going on with you, because it may help you understand other risk factors that may not be readily known. If your tests are negative, but you still have symptoms that you're worried about, keep asking questions. It may be that this may not be a problem for your gynecologist or whatever doctor you started with, but maybe there's another type of doctor you should see for further evaluation. So even if everything looks normal, if you're still having problems, don't stop there. Also, tell your doctor about any symptoms that you notice, even if you don't think they are related. Just like I mentioned in some of the symptoms before, a lot of them are similar in different types of cancers and different types of conditions. So you may not think that the stomach ache that you get after every time you eat is related to your GYN organs, but it can be. So it's important to tell your doctor about anything you feel like is abnormal. So it's a good idea when you notice things to keep notes of your concerns and make sure you bring those notes with you to your doctor's appointments. Also, I think it's important to keep a diary of your symptoms and include details such as time of day and any relationship to meals or certain activities. Be as specific as you can be. Your doctor will want to know what, when, how, where, what makes it better, what makes it worse, what have you tried to help it, and we'll ask lots of questions, and it'll be helpful if you have a diary so that you can really answer those questions and help give the doctor a better picture of what's going on with you. Also, take notes during your visit. Very often, when we have discussions about things that are very important to us, we may not remember everything, and we may have questions later. So if you take notes, you may be able to answer your own questions, and you can also, make sure that you know about any other steps that you and your doctor had discussed. On the same vein, it's sometimes important to bring someone with you. This companion can serve as an advocate and maybe a spouse, an adult child, another family member, a close friend, or even a community volunteer. It's important to ask, what else could this be? Your doctor may say, this sounds like fibroids. And if you're not satisfied with that, or if you're especially concerned because maybe someone in your family had another type of GYN cancer, you want to say, okay, maybe it's fibroids, but is there anything else that you might think is going on? And also, it's important to ask, what's next? You want to know if there are follow-up appointments that you should know about. Are there any tests that you're going to have done? And maybe how should you continue to monitor your symptoms? Let's say you have tests done and they look fine, but maybe you try one thing and you still have symptoms, or things get worse. You want to know when you should come back, what you should look out for, and what you should be concerned about in the future. So those are the things I think are really important that you take with you when you go see a doctor. So, and I put in a slide about reliable sources. I think it is helpful, just like we talked today about different types of GYN cancers. It's helpful to know what are the possibilities. So some good sources would be the CDC website, the American Cancer Society website. There's also a Memorial Sloan Kettering Cancer Equity Program. That's a good resource. And the Endometrial Cancer Action Network for African Americans. That can be helpful. So knowledge is power. So it's important for women to know what's recommended as far as screening tests, to know what's recommended as far as just staying on top of your own health and knowing what questions to ask when you go see your doctor. And that's it. Do we have any questions?
All right. Well, thank you so very much for an outstanding presentation. Yes, there are several questions I'm sure that folk have, and we'll be getting those in we have a couple in the chat coming up. You have one that deals with, are there things we do that might feed fibroids to make them get bigger, coffee, other substances, or is that a myth? Excellent question, I think.
Interesting question, yeah. I don't think we know of things that necessarily will make them bigger, but some of the things that you mentioned, like other coffee and other substances, things in your diet can make the symptoms better or worse. So caffeine is thought to worsen like muscle contraction. So your uterus is a muscle, so it might cause you to have more pain when you have menstrual cramps. And so that can sometimes seem to worsen the pain associated with fibroids. So there are some things that can affect that. It doesn't, there's nothing in your diet that I would say would cause fibroids or make them bigger. But there are things in your diet that can make the symptoms worse.
Wow. There was another question earlier in the chat, more of a statement, but they wanted to have you explain unusual bleeding and pain. Some women think that pain and menstruation are normal, but please explain what is unusual bleeding and pain.
Yeah, that's a good point. There is such a range. There are women who just have a few spots every month and that's it. There are women who wear adult diapers every month because their periods are so heavy, and they think that's normal because that's the way it's always been. There's a lot has to do with what a woman can tolerate, yes. But I would say that if your bleeding is so heavy that you have to do things that are, out of the ordinary, like using adult diapers, if you have to miss work, if you often soil your clothes or your sheets, things like that, that's very heavy bleeding. That's the kind of bleeding that can often lead to anemia, which means that you don't have enough. Your blood is working really hard to get oxygen up to all places in your body. So that's an important thing to consider. Pain as well. A lot of women, we think of our periods sort of like this is our plight in the world. This is something that we have to do, but we don't really have to suffer. There are lots of things that we can do to help alleviate some of the pain and discomfort that's associated with periods. The most important thing, I think, is that if you think something isn't right, you should talk to someone about it. Yeah. And if something changes, you should talk to someone about it. If you normally have a period every 28 days on the dot, and then all of a sudden you're having things every 15 days, you want to talk to someone about it. If your periods are moderate and then all of a sudden they're super heavy, you've not had that happen before, you should definitely talk to your doctor about it.
Sure. I do want to come to Dr. Clive Callender and Dr. Melanson, but before we do, I do want to follow up, since you were talking about heavy bleeding. Is there some understanding around what is considered to be heavy bleeding? Is there a certain flow in a given period of time? Can you share more about that? And how frequently should women go see the OBGYN?
Okay, so I'll answer the last part first, because that's easy. You should see your OBGYN every year. Every year, more often if you're having problems. And even if you're done having children, even if you're not having a period anymore, even if you had a hysterectomy, you still need to see your OBGYN every year.
Oh, wow. Okay.
A lot of women get that confused, but keep going. As far as bleeding, it's something that is hard to measure, but I can tell you the questions that I ask patients to get an idea. I ask, what do you use, pumps or pads, and how often do you soak them? Mm-hmm. I ask, do you have issues where you have to change your clothes? Do you follow your clothing or your bed sheets? And how long does it take for you to soak through a pad? We consider like emergency type bleeding is if you're soaking through a pad in an hour or less, then that's something where you need to go to the emergency room. But those are the kinds of questions when patients say I'm concerned about my bleeding, I ask them, how long does it take to soak a pad? How often do you soil your clothes? Do you ever have to change your clothes? Do you ever have to leave work? Like, does it interfere with life?
All right. Well, thank you, Dr. Alana Callender. Now, Dr. Clive Callender, Dr. Melanson, you want to chime in here?
Yeah, one of the questions that I've often been asked is, after you are 65, do you need to see a gynecologist anymore as a woman? No more periods, no more symptoms. You still need to
Yes.
see a gynecologist every year?
Yes, because women, we talked about cervical cancer, endometrial cancer, and ovarian cancer today, but women can also get vulvar or vaginal cancer, and those are a lot more common in older women over 65. Also, most cancers besides cervical cancer, ovarian and endometrial cancer also occur more often in women as they get older. So if a woman is not going to see the gynecologist anymore after her childbearing years, then how is she going to know something's going on that might be related to ovarian cancer or any complications like that? She won't know. But a lot of these cancers that we're discussing don't even show up until after those years have gone by. And even if you do have your uterus removed, ovaries, cervix, all of that removed, you still have the same, your body's still making hormones, and you still have the vaginal and vulvar area. And those cancers definitely, it can be cancer, but it can also be some other things that are benign that can cause symptoms that a primary care doctor won't really know how to deal with.
I want to ask one more question, please. My aunt died of ovarian cancer, and I have some friends who also died of ovarian cancer. That seems to me a cancer that is awfully hard to diagnose. Is there anything new around that would help make the diagnosis of ovarian cancer easier to make?
Unfortunately, ovarian cancer for us is exactly the opposite of cervical cancer. We know a lot about cervical cancer, ways to prevent it. Ovarian cancer is a very difficult cancer to diagnose. It's very difficult to prevent. There are some things that women can do. Essentially, the greatest people at the greatest risk of ovarian cancer are women who have not had children, women who started having periods early and stopped having them late. So one thing that can help with that is using oral contraceptives, because that sort of mimics in your body what pregnancy is like. And so that can help reduce the risk of ovarian cancer. There are also some medications that women can take if they have the gene that increases risk of ovarian cancer. That can help decrease the risk of ovarian cancer for women who want to retain their ovaries. But they're really, it's very hard to diagnose because there aren't any specific symptoms that are related to ovarian cancer. They're all very general and can be associated with other things. And women often spend a lot of time seeking help before they do get a final diagnosis of ovarian cancer. But most importantly, talk to your doctor about what things you can do to help prevent it if you are one of those women who are at increased risk. Definitely have in your family, if you have a history of ovarian or breast cancer, it's important to know that. And also you might want to get tested for any hereditary breast and ovarian cancer syndromes.
I have a question. So great talk, Dr. Alina Callender. I see the intelligence runs in the family. So
yes.
Yeah, and by intelligence I meant through your mom. Yeah, but anyway, I
Forgive him, Lord, for he knows not what he does.
So I've always read that hysterectomies are more common in women of color. So it just seems counterintuitive that you have a group of women that are getting more hysterectomies, maybe even inappropriately receiving hysterectomies, but at the same time have a higher risk of cervical cancer. So that was my first question. Then just as a follow-up, I was wondering, is there ever an indication for prophylactic hysterectomy and or oophorectomy with all the genetic testing and whatnot that's available?
For the first part, I don't really know. I don't know. I think you're right. There are issues. There are situations in which Black women would be more likely to have hysterectomies because they may not have the resources to try many of the other options for whatever their symptoms might be. But like, like you said, it still remains that we are dying more often. We're being diagnosed at later stages than white women. And even endometrial cancer is more common in white women, but we are dying from it more than they are. So there's a lot of possibilities of why that might be, but there's not necessarily one answer. And yes, if a patient is found to have a hereditary breast and or ovarian cancer syndrome, then we do recommend prophylactic oophorectomy or removal of the ovaries and maybe the breasts as well, because those the increased risk of cancer with those syndromes is so dramatically high. So it's important to know your family history and to know whether you are a candidate or whether that's something you should be concerned about and get tested, because that can definitely help you make a decision about what steps to.
Just a follow up. I'm sorry, but is it expensive to add this? Like if a woman, if you're seeing a lady in clinic, is it a huge expense to add a genetic test to her normal visit?
Nowadays, since they've been for a while, it's not. At one point it was, but generally, if a woman meets the requirements, basically, like if she has a strong family history, then that will be covered by most insurance companies. If it's something where a woman just wants to do it just because, then that might not be covered, and to pay for that out of pocket is quite expensive. But for the most part, like I said, it's really important for doctors to discuss history with their patients. And it's important for us as patients to know what our family history is so that we can determine whether we need to be concerned about these genetic disorders. Because there are definitely tests out there, and we're learning more and more about specific syndromes that are out there. So it's definitely a great tool to help a person determine what their plans should be.
It's very interesting, and I just want a quick question, then I want to go back to the chat. You talked about you need to ask questions of your doctor, and you need to continue to do this. And then you also talked here just about insurance as well. It seems as though, as you're talking about endometrial cancer, cervical cancer, and the like, getting second opinions may not always be covered by insurance. So what do you do? Because these things sound very costly to really start to do all of the testing. And now you're caught because of all of the things that women have to go through, particularly Black and brown women being vulnerable as they are economically and otherwise due to the other matters like high blood pressure, diabetes, etc.
Yeah, there are a lot of barriers in the United States to healthcare. Even with the Affordable Care Act, there are some states in the United States where people still don't have access to a lot of the preventive care that is covered by that. Especially like in the study in Georgia, there were women who don't have a single gynecologist in the whole county where they live.
Right.
So there's an issue with accessibility and barriers to care. When it comes to getting a second opinion and getting tests done, a lot of screening tests are available for free or for very low cost, because those things are done either at a lot of proper organizations offer them. Like there are like mammograms, that there's like a bus that goes around and you can get a mammogram. A lot of places you don't need a doctor's order even. You can just get a mammogram. A lot of places you can go to get your pap smear and things like that. The cost, of course, does come into play when, like, if it's abnormal, then you need to get the further testing. So there are definitely, I would recommend that women look for ways to get access to that care in their communities, because there usually will be some sort of free clinic or low cost clinic that is available, and that you'll be able to ask whatever the local hospital is, if they have any arrangements with other doctor's offices or things like that. But it's definitely an issue. But not having insurance doesn't mean that you can't get access to these things, because there usually is some way, although there are definitely places in this country where it's very difficult, and it involves traveling to see a specialist.
Yeah, it definitely involves traveling here in Washington in some portions of the city.
Yeah, yeah.
Other portions of the city. I'm in Southeast Washington, and there
Yep.
are very few, if at all, any gynecologists in this area of Southeast Washington until a new
Yeah, people
hospital.
don't think of a city like Washington,
Yep.
D.C. as like a healthcare desert, but it
Yeah.
can be.
Yeah. But I there's you mentioned HPV earlier, and there's a question in the chat, and I think you answered it in your talk. But if you could again say, when should girls get the HPV vaccine, and what's that sort of range that you talked about? I know it
Yeah,
was
thank you
started
for
at
that
like 8 or
question.
9.
Yes. So first of all, girls and boys can get the vaccine.
Oh,
right? It's a sexually transmitted virus,
yeah,
so
yeah. Girls
you
and
need girls and boys to get the
listen up,
vaccine.
YouTube, Facebook.
Girls and boys get the Gardasil vaccine. The earliest that it's given is at age 9.
Okay.
And it has started out from 9 to 26, but now it's the age of 45. So
45.
girls and boys, women and men can get the vaccine.
You said
And should get the
45.
vaccine. Yes.
All right.
Yep. It's
Okay.
very important. And I think it's most important to get it at the younger ages, because, as we understand vaccines, you want to get it before a child is exposed to any of these things.
That's right.
So at 9, it's a great time to get it done and not worry about it. And it really has, just in the time that I've been practicing, I've seen a huge difference in the amount of cervical cancer, a huge difference in the amount of abnormal pap smears. There's lots of testing that we do, or lots of testing and treatment that we can do before cervical cancer ever happens. But because of the vaccine, I don't do a lot of that anymore, because I just don't see it. I don't see as many abnormal pap smears. I don't have to do as many procedures. It's been less than 20 years since the vaccine has had wide availability.
So that's interesting. And I have just a host of questions, and they're probably more personal than anything else. But I would ask that Dr. Clive Callender, Dr. Milan's son, you join us here with your questions. I know I have one that I want to get to first in the chat, but it would be very interesting to talk more about what are the causes of these cells that are abnormal in this particular area. Can diet help them? Can we do anything with regard to the formation and the origin of these abnormal cells?
Yeah, actually, to follow up on your point, Reverend, I was just wondering, we talk on this show a lot about preventative medicine, preventative care, or changes in patients' lifestyle. Is there anything that women can and should be doing that would decrease their risk of any of these sort of malignancies, like diet or exercise or being under a certain weight or things of that nature?
Um, for the most part, the same kind of advice that we give everyone about maintaining a healthy weight, eating a healthy diet, and those would translate into gynecological cancers. The one cancer that is most affected, I think, would be endometrial cancer, because often that's part of a metabolic syndrome. So that women who are obese, women who have diabetes, hypertension, they are all more at risk of getting endometrial cancer. So maintaining a healthy weight and keeping those other things under control can definitely decrease a woman's risk of endometrial cancer. And that's true, like with cervical cancer also. Just like if you think about, there's a virus that causes cancer, so you want to have a strong immune system.
Yeah.
So like, let's say if you get infected with this virus, the virus doesn't, it's very slow moving. So from the time a woman gets an abnormal pap smear to the time when she has the lowest grade of cancer could be 10 to 15 years. So it takes a long time. So, and that infection would have to be persistent that entire time. But if you have a strong immune system, you can have, if you eat well and exercise and do all of those things that we always tell patients, then you can keep it at bay. You can keep it suppressed in the immune system. So all of that advice definitely also applies to cancers.
Yeah, I want to ask. It's a little bit different, but I recently was asked to consult on a patient like this. These patients, we're seeing more and more of these transsexual patients who have had gender reassignment surgery. Who do they follow up with? I know that a gender, someone that's become female or changed their gender or whatever, they're not going to have a uterus, but they now will have different sort of anatomy. Do they follow up with someone like you? Or I was just wondering.
Gender reassignment surgery doesn't necessarily involve removing the inner GYN organs. So as long as those are there, it's important to monitor them. And it's harder, I would think, if you're not having periods or anything that you would notice a change in. So, but I think as long as you, it's the same thing as with other women. If a woman has a hysterectomy, she still has to be a gynecologist because she still is at risk of the same kinds of cancer. So regardless of the type of cosmetic surgery a person has had, if a person is born a woman, a female with female gonads and everything, then she's still at risk of these cancers. Ovarian cancer, if you remove the ovaries, it's much less likely, and so on with their cervix, but still there's other possible issues that can arise.
I had a question. There's a recent HHS requirement that before a woman gets a pelvic examination, or a male gets a pelvic examination, that they have to have written consent. What are your thoughts about that? My thought is that through the decades we've done pelvic examinations on men and women when they've had medical reasons for it to be done so. But now they are saying if you do not have a written consent, you can't do a pelvic examination. And if you continue to do so without permission, you won't get HHS or federal funds.
Wow.
That's a new ruling that just came out by HHS. What are your thoughts, Dr. Callender?
I think that's silly. I think that I'm a gynecologist, so if you come to my office, you basically have consented to a pelvic exam because that's what we do.
Yeah.
If you consent to treatment by a gynecologist, that's included. Kind of. You have a complaint that involves your pelvis, and you want me to evaluate you for it, then you've consented to a pelvic exam. We don't ask for written consent for every single thing that we touch on a person's body. I don't ask for written consent or anything specifically. When you come to the office and say, I want you to take care of me, that's essentially giving consent. And at any time, you can withdraw that consent. If someone, maybe it's like a woman's first exam. She's never had one. She feels very uncomfortable. She's not ready. We don't do it. She changes her mind. We don't do it. We listen to her, and she's ultimately in control. But I don't see why a gynecological exam should be any different than any other exam.
Well, I would tell you that the reason this came to pass is that at certain, and it doesn't apply to offices, it applies to hospitals. And at certain hospitals, the trainees would be allowed to do pelvic examinations with the woman under anesthesia without giving any permission. And so this was to address that, why they came up with the law. You're right. It doesn't apply to the offices, but it does apply to
I understand what you mean. Yes. We did that in when I was in residency, and I will say that when I felt uncomfortable with that as a resident, because the woman doesn't know what's happening. So yeah, I think that's different because again, I'm a gynecologist, so this is what I do. So generally, a pelvic exam is not out of the ordinary for me to do when I do surgery. It's part of the surgery. But I guess if the question is whether the 3 students in the room can also do an exam, then that's different. But I think that we, in our consent forms, we do ask, especially at teaching hospitals, we ask if the patient would allow to be involved in their care.
And I think in that care, you think that if you're a doctor doing it, you're not thinking of residents and other medical students doing it. And I think that's what it's aimed at, but in the same time, it may interfere with other issues. So I just wanted to hear your ideas on it.
Yeah, I kind of feel like it sexualizes women in a time when it's not necessary to do so. Because like I said, we don't ask, we have these consent forms that we don't ask for every single thing, written consent for every single thing that we do, every part of the body that we touch. Having my hands inside a patient's abdomen or a student's hand inside the patient's abdomen, that's major, right? And we're separating this part of the body to get written consent for what is a particular reason for that.
Yeah. Dr. Clive Callender, so that our audience is clear, written consent or permission was from who? Is it the person? Who is that written consent by that HHS?
The person, the patient.
The patient. Okay. Patient. I think that should address the question that was raised in the chat. We said that earlier that you should work out, you should have a proper diet. Is there anything else we can think of that could be done to prevent these cancers? I know it's $1 million question. I wish we could solve cancer tomorrow, but man, is there anything? else that women should do so that we can keep our women alive and strong and vibrant for a very long time?
And let me just add on to Reverend Curry's point question. There's a lot of herbal medicines that are touted to improve women's health as
That's
far as
true.
the uterus and the ovary. So I wonder if those things would be recommended uh, by you, Dr. Calendar.
Okay, so cervical cancer is a winner, right? Like we have a vaccine,
Yeah. Yeah.
we have our pap smears and HPV testing. And so that is something that we definitely can prevent. And the other things, like ovarian cancer, as I mentioned, sometimes oral contraceptives are recommended in order to prevent or decrease your risk of ovarian cancer, especially for women who haven't had children or women who have a hereditary cancer syndrome. Getting tested for hereditary cancer syndromes would be important if you have a family history.
Sure.
Knowing your family history is very important. I know sometimes in Black families, we don't like to talk about a lot of things, but it is important that we know what's going on so that we can use that information to direct our own care. And somebody mentioned that in the chat that like when you see your family at a family reunion or even at funerals and things like that, it's a good chance to talk to people and find out what's going on.
Yeah.
Because there are ways you can stop, if this is something that keeps happening and happening, there are ways you can help stop that. I would definitely say that, again, the things that we consider as being healthy, to keep recommending those things: exercise, eating well, and seeing your doctor to make sure that your blood pressure is normal, that if you have that you don't get diabetes. If you have diabetes and you keep it under control, maintaining your health overall is going to help decrease the risk factors that exist for these other cancers. So those are some of the specific things and more general things that I would say. Oh, as for herbal remedies and such, there aren't any things that I necessarily recommend, because those things aren't studied the way other pharmaceuticals are studied. So it's hard to say with any confidence whether they are helpful or not as far as preventing cancer.
There's some data that eating plant proteins in preference to animal protein may help decrease the incidence of some of these gynecological cancers, especially endometrial cancer. Any comments about that?
Yeah, I've seen some of that research, and I think that is that's really important. And I think that's part of eating a healthy diet, and also eating a diet that helps the whole planet as a whole. So I think leaning towards more proteins from plants rather than animal protein is definitely important for overall health.
Wow. Well, we have run out of time, unfortunately, for this segment, but that means Dr. Elena Calendar has to come back, and maybe she can replace Dr. Malone. I'm just kidding. Since brilliance runs in the Calendar family, we want to make sure that we have all of the brilliance. But thank you so very much, and Dr. Elena Calendar, and for your comments, for your presentation, as well as the answers to questions. And we look forward to having you back real soon. And certainly, as
Thank you
always,
for having me.
you're more than welcome. Certainly, as always, Dr. Clive Calendar and Dr. Joseph Melanson, par excellence. We thank God for you, and all of you, in fact. And we just look forward to another segment of Kidney Talks coming soon. And so thank you all. Have a fantastic day. May God bless you and stay healthy out there.
Yes,
Be
sir.
well. Bye bye.